Please be aware that this recording contains mention of sexual assault. Hi everyone, it's Rachel. I am the founder of About Your Body, and I am so excited to bring you the About Your Body podcast. This is something that I've been working on for quite a while now, and I am so excited to bring you experiences of biofemale people, hearing from doctors and health practitioners about the biofemale reproductive system and biofemale health, all with the aim of reducing the stigma and fear around biofemale health. So today we are talking to Dr. Natalia Carter. Natalia is a GP, which means a general practitioner working in Australia, and I am asking her some basic and not so basic questions about biofemale reproductive health, biofemale health in general, and what it is like working as a doctor in Australia, seeing primarily female patients, but definitely not entirely. We talk about that as well. Without further ado, I really just want you to hear what she has to say. She is an amazing and accomplished woman, and I'm really proud to know her. And I'm so honored that she would share her time with us to help educate us and destigmatize the fear surrounding our own bodies. So let's get into the interview with Dr. Natalia Carter. Hi, thank you so much for being here. I'm so excited to talk to you today, and I'm excited to get an insights into all things biofemale health and all things reproductive health. And today we're just going to cover some basic questions, but how are you doing, for starters? How are you doing working in a clinic in a pandemic?
It's better than it was. It was very scary to start with, but because our country's been doing very well, it's not quite so scary, and it's almost back to normal.
Good, thank God. I mean, yes. When you're not working in healthcare, life feels pretty average, pretty normal, I must say. However, I don't think that's the case if you work in a hospital. I'm sure it's pretty scary.
Yes. And we have to be more cautious than we used to be, even in our private lives, personal lives. You know, we can't just go anywhere we want to in case somebody with COVID went to that place, and then we can't go back to work again for a couple of weeks.
Yeah, that's very true. It's very I'm getting a bit over it, I must say, but so
well, yes, everybody is.
Yeah, I'm not alone in that. So you're a GP, which means general practitioner, and I know that being a GP means you deal with like a huge variety of issues and a lot of illnesses at work. What is on the day to day? What kind of issues and illnesses do patients present to you with?
So it'd be different for every GP. Depends on where you work, what kind of practice you work in, and how many hours you work. But for me, on a day-to-day, I would see a lot of people with mental health problems, a lot of women's health, a lot of children, particularly they're just sick or they're having vaccinations. I see a lot of elderly. I have 30 patients in a nursing home. And we see a lot of people with long-term chronic illnesses. And I particularly also see people who are struggling with obesity and chronic pain.
Right. Have you chosen to specialise? Sorry.
No. So it sort of comes about, I don't know, either people get to know that you're good at something, or you get invited to do something and you become a bit more kind of expert at it, or something just came up. So, but also because I have a lot of patients, I'm pretty much booked out 1 or 2 weeks in advance, so I don't get to see little things that happen on the day when people might have a bladder infection or a runny nose, or tripped over and maybe sprained an ankle.
I mean, congrats on having a lot of patients. From a business perspective, that's fantastic.
Well, I've been around for a while in one place.
I mean, obviously you can't know an answer to this, but I'm going to assume that the most of your patients are women because you're a woman. Do you think that's the case?
No. Now I can find out the stats on that, okay. and it often feels like that. But I do have quite a few men. But I must say, women tend to come to women about women's things, and the men tend to go to the men about men's stuff. So men that I might see for all sorts of things tend not to come to see me about their stuff.
Yeah.
Or I've got other women who aren't actually my patients. They don't even come to our practice and have a lovely, very competent male GP and say, but I've just come to you for my pap smear, okay?
Yeah. I mean, that's, fair enough. It's very...
I go, that's fine. That's fine.
Very intimate.
Yes.
I assume you do, I don't know, a lot of them every day. Perhaps not. But when I was working at the medical centre that I worked at for 4 years, just as a receptionist, there was one female doctor there for a while, and I think she did 10 paps a day. Like that was half of her job. Yeah, she was good at them too.
No,
she does my pap smears as well.
Yes. So I get to share them around, but I do some days feel like I do more than everybody else.
Yeah, right. Okay. And you're not the only female working in your clinic, are you?
No. I think we have about 17 doctors and 3 are male.
Oh, well, there you go. How's that for subverting the usual statistics?
Absolutely. And we have a single owner, and she's a woman.
Oh, and she's amazing. I don't even know who she is. That's awesome. That's really, really lovely to hear. Do you work full time?
Yes.
So on About Your Body, we focus on the health of people with a biofemale reproductive system. So usually that's women, but not everyone who has the biofemale reproductive system is a woman, of course. And I know obviously have a lot of patients who are women or women identifying. I would love if you could outline just some of the main issues that those women or women identifying people present to you with.
Lots of times it's about periods.
Okay.
That they're heavy, they're painful, they're too often, they're not often enough. Are they normal? That's a big one. Another one is sexual health kind of stuff. So either about STIs, about sex not working or sex being uncomfortable, or am I bits sort of normal, or is it working properly, or they've been abused or assaulted. Women come about their breasts often, they're sore, or they've had breast cancer, or they have trouble breastfeeding. Also, a lot of women come about menopausal symptoms and a huge range of those sort of things. Women also come about their vaginas, like is there funny discharge? Does it hurts there, or it's itchy there, it's smelly, they've found a lump in it. And then I guess not so specific to women, but bladder issues. I mean, men have bladders too, but they don't tend to have the incontinence or leakage that women do.
Does that generally happen because someone's given birth or had a baby?
That's the most common reason. Yeah, most common. But there are other causes. Yeah. So people who've never had babies can also have a problem.
Oh, that's a shame.
Yes.
I thought that was the way out, the way to avoid that. So not.
No.
So even discomfort or pain during sex, do you see a lot of that?
Not a lot, and I'm not sure it's because it's not common, but I think it's because people are too scared to talk about it, or don't know they can talk about it, or don't know they can come to me to talk about it.
Yeah, I mean, I have a theory, and that's that based on nothing, but just that people, I think a lot of people don't realise that sex is not supposed to be painful, and that perhaps if you have a vagina, it might be painful the first time, like there's a higher chance it'll be painful the first time, but then after that, it shouldn't be painful. I would even say it probably shouldn't be uncomfortable, but it should actually be pleasurable. Yeah. But we come to accept a certain very low standard, and I think that's because we don't talk about things like that. And what I want for the future generation is that they don't get to 60 years old and realize then that sex is supposed to be pleasurable. I want them to realize that when they start having sex or before.
Yes.
Before is even better, because then you'll be much less scared to have sex, and I think fear is a big factor in that. Talking about periods is a big topic of something that we do on the page a lot as well.
Oh, good. Because that's actually another thing I've found, that people don't realise that their periods are not normal, or they don't have to put up with the way it is.
Is there a bell curve of what is normal, and then somebody who sits on the outliers, you can actually do something about that?
Most people you can do something about. Absolutely. But people don't know that. And it's actually been sad to see women come to me saying, but they told me there was nothing you could do about it. So that's not true. We can do lots. We can make life either much less uncomfortable or much less disabling. Some women's periods are so heavy they can't leave the house for a day or two. And you can do something about it. So maybe 25, 30 years ago, there were fewer options, but there's so much more available now.
And is that option usually contraception, hormonal contraception, or?
Depends on the age of the person and whether they're planning to have babies later or not, or if they've finished having babies. So there are more options if you are not planning on having babies.
Right.
So it can be. Yes, so it doesn't have to be something that's also used as contraception. It doesn't have to be hormonal. It can be surgical. And it doesn't have to be a hysterectomy either. So
I was going to ask.
It can be anything. So a thing called an ablation is a good option. So ablation basically means burning. So there's a special device that goes into the uterus and basically microwaves the lining. And magic, no periods. For about 85% of women, it's effective.
No periods ever. So get rid of the entire uterine lining. Oh, wow. But you can still keep your uterus, so you don't have to have the huge operation that sounds very painful.
Exactly.
Wow, I didn't even know that existed.
It's much safer. See, not many people do.
Is a hysterectomy an operation that you would only refer people for if there were no other options?
Yes, if there are no other options.
Right, okay. Yeah, it sounds a very... it doesn't sound nice whatsoever. So I'm pleased to hear that ablation exists.
Or we've tried the other options and they've not been effective, and it's still impacting on a woman's quality of life. Or their periods are so heavy that they're so iron deficient they're exhausted.
Yeah. Is it usually, would you consider it up to the patient to decide whether or not their periods are affecting their quality of life? Is it if they are willing to put up with it? Like, how do you determine?
Absolutely. Yeah, no. It's up to a patient. It's not for me or the gynecologist to decide.
Okay, yeah.
Some people don't put up with very much, and some people are very stoic.
Yeah. I mean, my own long ago, not that long ago, I'm not very old, but my own few years ago story is that my periods were so heavy. I had a 21-day cycle instead of 28, which I suppose is just my natural cycle. So that's a shame. And I would have periods for about 10 days long, and they would be heavy for 5 days. And that was like, I thought that was normal, and I was so exhausted. I was so tired. And Mum, who you know very well, who is also a doctor, was like, Rach, that's not normal. You shouldn't be having periods that are heavy, that heavy, like we're talking clots for 5 days. And then I went on a hormonal contraception that stopped that, and I have so much more energy now. Yeah. But it does lead.
And more freedom.
Yeah, I think contraception is like, regardless of, I mean, it's a choice whether you want to take it or not. And I really don't want to be on contraception for my whole life, because it really messes with me in a lot of ways. But the choice to be able to, in some ways, control your body is the greatest gift. Like the fact that we can all have sex and know we're not going to get pregnant. Well, I suppose not know. Very, very unlikely that we're going to get pregnant.
Reduce the chance of it.
Is fantastic. And I can't believe that it wasn't long ago that, or actually in many parts of the world now, still that's not an option. So that's why
still not available.
Yeah, and I'm doing
Yeah.
a series on contraception at the moment, and I'm covering all of them, and well, not all of them. I've definitely missed some, but I'm trying to cover all of them. And the ones that there are some that I'm covering, for example, like the diaphragm. That I'm like, I don't know a single person who uses that anymore because there are so many. I know people do, but there are just so many options.
It's very rarely used in Australia now.
Yeah, we're not in the 90s in an episode of Sex and the City, so it's not as...
Yes. And it's still much more popular in the States
really?
now than it is here. Yeah.
I have a theory that is because...
options too.
Oh, I was actually thinking that it's probably because they don't have universal healthcare in the States, so it costs a lot to get, for example, a coil put in.
Yeah.
Whereas
yes, you're probably right.
Yeah, I can't imagine having to, like, it's expensive enough to get a coil put in, and it's like not expensive. Like
yes.
Yeah. Do you insert IUDs or take out IUDs, or is that something that you would have to refer to family planning for or a gynecologist? And for everyone listening, IUD is intrauterine device.
So no, I don't insert them. You need to do some training for that, and you need to have the opportunity to insert them several times a month to be good at it.
Oh, okay.
And so I do refer to a gynecologist or to a colleague, or other places like family planning or Marie Stopes. They do them as well. Yep. I can take them out easy peasy. Don't need any skill
you just
to
grab.
do that. Yes. Yeah. You need a special grabber that's long enough.
Not your hands.
And a good life. No, and a speculum so you can see.
Right. Do you I won't get too much into speculums because we'll be covering that another time, but do you use different sizes of speculums on different people?
I tend to try and use a small one on everybody if I can.
Right.
And almost always that is big enough for everybody. Sometimes some people's vaginas are a bit longer, and I need one that's a bit longer, and to make it longer they also made it a little bit bigger, which is still medium. It's still the ordinary size.
Right, so you're never using the extra large speculum.
I've never used an extra large ever.
Okay.
But I'm sure gynecologists would.
Yeah, okay. That's good to know, because I never even want to see an extra large speculum if I can afford it. I am a very small person. Does it depend on the size of the person whatsoever, though, or is it purely on the width and of the vagina?
So no, sometimes a larger lady it's a bit longer to get down the vagina.
Okay, right. So it can be affected by that.
So you need it, yeah.
Right. Okay, that's really interesting. But just seeing the different sizes. Look, honestly, to somebody who is a lay person who doesn't work in health, the smallest speculum is bloody big enough. It's not that big, but it's big enough.
When we get to it, I'll show you that it's not as big as you think.
Okay, thanks. That'd be good. I would love if you could give your opinion on whether you think that young people, but particularly people with a uterus, for example, are given enough information regarding contraception, in particular the pill, because growing up when I was in high school, every second person or more than that is put on the pill quite young, but it's not often. It is sometimes because they're sexually active, but other times it is for their heavy periods and etc. And I personally think that later on it becomes evident that we hadn't really thought about it when we went on it. We just went on it because the doctor said to, which was probably a good idea, but I think it's important to be aware of what you're doing to yourself. Do you think there's enough education surrounding that, for example, in schools or just in general society?
I'm not actually sure what the schools provide. My only experience is from my own daughters.
Yes.
Who will say, "Oh, we already learnt that, Mum. They told us about that at school." And then I can't really speak for other GPs. And I tend to often call the pill I don't actually call it contraception because I use it for so many other things, and I try to explain to particularly younger teenagers and their parents that it's hormone treatment, and it doesn't mean that they're ready for sex. It's just to help with their acne or to help with their periods and their pain.
Right. Okay.
And it does not mean that I'm necessarily giving them a reason to have sex, or that I'm saying that they're ready for sex.
Yes. No, that's a really good point. I think I went on the pill for the first time because I started on Roaccutane, and
Accutane,
I
yes.
believe it was a requirement, at least at the time.
Yes.
Because
no, it still is.
Yeah, it is.
Because
Okay.
because Roaccutane's very dangerous for fetuses, so we've got to make sure women or people with a uterus who are taking Roaccutane don't get pregnant. That's why I say this is hormone therapy. It's not a sign on your forehead saying I'm ready for sex.
Okay, that's a really, really helpful distinction. Thank you.
Yes, because also parents who come with their daughters are also worried that that's what I'm doing as well, that I'm telling them they can have sex, and what I'm trying to do is improve their acne or improve their periods.
I'm wondering how you navigate a conversation where a young woman might come in with her mother or her father, and she's 15, for example, and you think that maybe she is having sex, but you're not sure whether to say it or not. Do you ever have do you have a method of navigating that, or do you just play it by ear when it comes to, depends how nice the mother seems or how open the daughter is being?
It's a lot to do with how open they are with each other.
Right.
Because some of them will clearly haven't had sex and have mother talk to me about everything.
Yeah. Okay.
On their behalf, because it's clearly about their pimples. But I often will say, and just for the last couple of minutes, I'll get mum or dad to step outside, and so that I can ask you some other questions. And the parents, although we're shocked, are always happy to do that.
Oh, that's a great tactic. That's works well. I'm glad that they're always happy to do that.
Most of the time the person is completely shocked and goes, "No, my God, I'm not doing that." Then it's an opportunity for them also to say, "Actually, yes," and they don't know, so please don't tell them.
Yeah.
And then that's also my opportunity. Well, actually, not just then, but often I will say in front of the parent, now that you are 14 or 16 or whatever, you're entitled to get your own Medicare card. So even if you still want your parents to pay, you might like to have your own Medicare card, because then you don't necessarily want them to know that you've been to the doctor or that you've had a test done. So if for example, I am checking you for chlamydia, you probably don't want that invoice to go back to your parents, so that they know that their child is able to come and talk to me openly and honestly, and that I'm not allowed to tell the parent.
Yes. Okay. Fair. That is the confidentiality comes before all. Do you see people generally for fertility issues, or is that something that you have to refer on to a fertility specialist or a gynecologist? Do gynecologists deal with fertility
specialists? Yeah, so they are gynecologists, yes, but they tend to specialise in fertility. So I guess I'm a GP, so I'm first point of call for everything, including fertility. So I will take a history, and often people just haven't been trying long enough.
Okay, right.
And there's probably nothing wrong, and they're still young and they've got loads of time. But if they've been trying for 12 months and not fallen pregnant and have actually had sex plenty of times, then I will refer them. If they happen to have a condition I know that's going to be difficult to fall pregnant, then I'll refer earlier. For example, if they've got polycystic ovarian syndrome and have like 2 periods a year, then they probably only ovulate twice a year. So chances are very slim of falling pregnant without some assistance, or being very patient.
Right. I was going to ask about PCOS, so that's great. Thank you. Sorry, polycystic ovarian syndrome. PCOS is just much easier to say.
Yes, it is.
In your experience, is that a common condition? It sounds a lot more common than I ever thought it was. However, I know that it's because it is a syndrome, you have to have 2 of the 3 symptoms to be diagnosed with it. and the symptoms could be to varying degrees, so it might be a bit all,
Absolutely.
up in the air.
And sometimes we don't put it all together until somebody's had an ultrasound or is having a lot of trouble losing weight or is having trouble getting pregnant, or just haven't put it together and gone, wow, you've got all these pimples and we never really thought of that, and notice now you've got lots of cysts in your ovaries. Okay, that's probably it.
Right. I suppose it must be easier to tell when, for example, like a young girl is growing facial hair. It'll be like,
Yes.
well, I can tell that's hormones. Whereas
Yes.
acne, actually, no, not all. I wish we all got acne so it was an even playing field, but some of us are not as lucky as others, like me, who ended up on Roaccutane 3 times. But anyway, so I suppose it's harder to tell when it comes to symptoms like that. Do you know if PCOS actually affects your ability to conceive? Does it just affect the time frame that you have to conceive? Like, for example, if you only ovulate 2 times a year, you can only get pregnant. If you're not ovulating, you can't get pregnant. That's what contraception does.
So exactly. So you need to drop an egg to be able to get pregnant easily, because you need an egg and a sperm. And if you have lots of cysts, a lot of those people do not ovulate. So if you're not dropping an egg, you're not getting pregnant.
Right.
So it does impact for a lot of people on their fertility. But some people with PCOS have periods every month and therefore are probably ovulating every month. But you can have testing done to see how often you're ovulating. And that's what I refer people for. That's not something I do.
Right. You can have tests, like, is that a blood test, a urine test?
Bloods, yes.
Bloods. Oh, worse. No, I'd rather a urine test. That's okay. Okay, thank you for clarifying that. That was a very commonly asked question, was can we touch on PCOS and fertility? This is a bit of a different shift, but you mentioned you see a lot of patients for mental health issues or issues of mental stability, perhaps. Have you noticed a shift in this in the time that you've been practicing as a doctor? I know that the GP is the person that is the port of call. Psychiatry is, of course, the specialty for mental illness. But mental health and mental illness are not exactly the same thing either. So I would love to know if you have seen a shift in the time that you've been working, or
I feel like there's a lot more mental ill health. But I guess the best way to know that for certain is to actually look at the data. And there used to be, when I first started in general practice 10 to 15 years ago, there was a study that would look at people in the waiting room and what they were going in for. So we actually had much better data on what was actually going on, not what we thought was going on.
Right.
And me particularly, I think I see a lot more mental health because I've already had experience. I already have a degree in psychology, and I did a year of part-time training in psychiatry as part of my GP training because I already was interested in it. So, and I think then once you start to have some confidence in it, people know about it, and then they recommend you, or your colleagues recommend you, or other specialists recommend you. But so I'm not sure if I'm seeing more just because people refer more to me or because it's an actual thing. It's definitely an actual bigger problem in the last 12 months since COVID. Had a huge impact on people's mental health. I saw lots of people who'd never had any mental health problems, who didn't have the words to describe their feelings and their emotions and the way it was impacting on them because they'd never experienced it. And it was purely the impact of COVID, either lockdown or the change in their work environment or seeing their family or loss of their routine. The things that have kept people really well without us knowing that's what it was doing until it was taken away.
Do you see, well, from my experience, so your daughters and I are really similar age, and as social media and when I was at school, it was Snapchat, started to grow so immensely. Like, to be honest, I don't really remember a time where there was no social media. I definitely don't remember a time where there was no social media, but I remember a time when there was less. As soon as Snapchat and Facebook started to grow, there wasn't Instagram at that stage yet. or at least it wasn't popular, mental health as the subject of bullying, like cyberbullying, became a massive issue. And then further from that, even if people weren't being bullied on social media, body positivity became a huge issue. I just would assume, I could be completely wrong, but I'm going to assume that in young people, there's probably some heightened states of anxiety kind of at all times. You definitely get used to not switching off. Like the first thing that I do in the morning is check my phone. Terrible habit. I know I need to stop that. But it's really hard to wake up without the blue light now. Like you get used to it. But the first thing I do is like check Instagram. The last thing I do before I go to sleep at night is check Instagram. So, and then I suppose with COVID, with that, there was nothing to do for a while there. A problem in a way we're lucky to have. We're not in a war-torn country. We can stay at home. But then you really are just scrolling all day, every day. If you have happened to lose your job, which a lot of us did. So I am saddened, but not at all surprised to hear that this was a rise in mental ill health. Are you able to describe what the difference is between mental ill health and mental illness? I don't think I quite understand.
I don't know. I prefer the word ill health to illness. I don't know why. Not everything's a disorder. So I'm very clear that not everything's a mental disorder. But we are sometimes, our mental health is not good, just like our physical health is not good necessarily. But it doesn't mean we need to pathologize it and that everything needs to be considered a problem that needs complete fixing, I suppose. Does that make any sense?
No, I think it actually does. The word disorder is helpful. For example, there's a difference between being between being very organized and finding it stressful when you're not organized, and having clinically diagnosed obsessive compulsive disorder. They're
absolutely
very different things. Yeah. Okay.
Yes.
Thank you. No, that does make sense.
Yes. And sometimes, being worried and sad and anxious and, losing sleep is actually a normal reaction to what's going on. It doesn't mean it's a disorder. It doesn't mean it, your dog may have died.
Yeah.
Or you've got, you're about to move house. Big stressful events will do that to people. It doesn't mean it's a disorder. It just means it's a horrible time that you're having some horrible feelings.
Yeah.
Or it's impacting on you physically, but it's also a normal reaction. And when it keeps going on and on despite that awful thing having gone away, then that starts to impact on your mental well-being. And then eventually, if it's impacting on your relationships or work or study, and day-to-day activities, then it would be called a disorder.
Okay. That's a clear distinction. Thank you. Do you have to undergo special training to be able to, or do you have to undergo something that differentiates you to be able to diagnose or determine when somebody does have a disorder and needs to be referred on to either a psychologist or psychiatrist, depending on what it is, of course? Do you have how do you, so we were talking before about if somebody thinks that their period is impacting their daily life, then it is impacting their daily life. But I know that with mental health, it can be very hard to tell when you're in that space. It can be very hard to understand what's happening, and sometimes somebody from the outside has to look on and determine. So did you, in medical school at least, learn how to determine that? Or is that something that you think comes with the job?
Very good question. So everybody does all the same training at medical school. So everybody learns a bit of gynecology and a bit of lungs and a bit of heart. And so we all did some psychiatry too. A lot of general practice training does include psychiatry and mental health. You can do extra training as well. But again, I guess it's like all other parts of medicine. We're not the specialist in that particular field. So we, for example, if it was a a gynecological issue, we don't do the surgery for that gynecological issue.
Okay.
You need to send to a specialist. And sometimes for mental health, I guess we've had enough training and enough experience seeing people every day that we know that somebody needs either psychological help or some medication or some other things changed in their lives.
Yeah.
And sometimes, despite what we've done, it's not helping, and we refer to a psychiatrist. Some things are psychiatrist specific, like ADHD. We can't prescribe medications for ADHD as GPs.
Is that because it's a highly addictive medication, or is it a high risk?
No, yeah, I guess high risk, specialised, kind of like Roaccutane. I can't prescribe that, even though I can see when somebody needs it.
Yes. I didn't realise you couldn't prescribe that.
No. So those people go to a dermatologist.
I see. Okay.
Yeah. And some GPs even do enough training that they can do psychological strategies, like almost like replace a psychologist.
Okay. Yeah. Right. I suppose knowing the GP is generally of all of the doctors that one might see in their lifetime, I think the GP is generally the one who knows you the best if you stay living in the same area, because you'll see them for everything before you even can see anybody else, unless you want to pay a non-refundable, non-Medicare rate. And so I suppose having that history, knowing the history of the patient and understanding that 3 years ago they lost somebody in the family and you remember that they didn't deal with their grief straight away and perhaps it's coming back now, things like that. As an example.
Or you remember that they were a very happy, bubbly person and now they're, don't look like they've showered for, days and they're not making eye contact. You can see the difference. The other part of helping work out, does somebody need help if they can't see it themselves, is often family will come.
Right.
Family will tell us or friends will tell us. And sometimes if you're so down and can't remember what you used to be like, it's helpful to have other people tell a GP what they used to be like and what they've noticed as different.
Right. So somebody could, you can go to your GP if you're worried about somebody in your family on behalf of that person, and that's something you're allowed to do. You can go and say, I'm here to talk about Rachel, I'm worried about her.
Yes, you can provide information. The GP just can't give you anything back.
Yes, of course, yeah. No, that makes sense. I don't know how that works billing wise, but that's but that's good to know. So if anybody is worried about anyone, that's always an option, at least in Australia anyway. That's good, thank you.
Yeah.
My question that I've written down next is, what is one thing that every young person with a uterus should be mindful of? Do you have an answer? And it can be more than one thing.
Very difficult question. I say a young person with a uterus they should know that they're beautiful when they're young.
The uterus or the person?
The person. Yeah. But is the question more about uteruses or about being young?
No, it's more about uteruses. We can even take out the young.
Uteruses?
Yeah.
Okay. So uteruses, they're much smaller than you realise.
Oh, okay.
Yes, I wasn't till I assisted a gynecologist and saw them one after the other that I realised how small they are. They cause a lot of problems.
They certainly do. Thank God for those ablations that we've got.
Yes, you can bleed from them. You can get infections in them. Babies grow in them. They fall down out of your vagina.
That a prolapse?
Yes. Ooh. And you can get cancer in them.
Yeah. When somebody has a baby and their uterus, so they've been pregnant for 9 months, their uterus expands to the nth degree. I can't believe how much it is able to expand. When it contracts back to, I would say, normal, non-pregnant size, does it go back to as small as it was before you ever got pregnant, or can it never return to that size? Do you know?
I don't know, but I think it does, based on So I assist sometimes with cesareans. So I've seen a uterus at the time of delivery.
Right.
And they're huge and they shrink very quickly though. So
right.
a woman is given medication to help the uterus shrink down. Massaging it makes it shrink down. So I'm not actually sure how long that takes to come back to normal size. But if you look at women's uteruses when they're 40, 50, 60, they're little.
Right. So I suppose they must go back to normal size.
Unless they're full of fibroids or cancer or something like that.
Yeah.
But a normal uterus later on is small.
I have explained what a fibroid is on this account before, but for anyone who doesn't know, do you have like a one-sentence explainer of what a fibroid is? I know they are quite common as people age. Yeah. Not for younger people usually, but yeah.
No. Much. It's older. So this isn't very technical, but I say like this growthy thing that takes up some room and often bleeds.
Oh, really? I didn't know it bled. Will it bleed through the cervix and come out as like a withdrawal bleed? Yes. Okay, right.
No. And that's why women have heavy periods and clots, because they've got fibroids in there.
Oh, right. That makes sense. At what stage... I'm not sure if you will be able to answer this question actually, because this might be something that a gynecologist deals with or even a radiologist, but at what stage would you consider a fibroid an issue? Like, does it have to be causing, like if it's a 12 millimeter fibroid, it probably isn't giving you heavy periods. Is that correct? And in that case, would it not be an issue?
So a lot of women won't know they have any fibroids. We only find it if we've done an ultrasound to have a look for some reason, because a woman has come and said, I have heavy periods or I have pain or something like that.
Right. Okay. Yep. So it does tend to be, is it something that you just find happens the older you get, the more likely you are to get fibroids?
Yes. And they're not common in young people.
Right, that's good. Okay, and I know that modern medicine now, modern technology is able to pick up fibroids much smaller than they used to be able to. So now if a fibroid is only 1 centimetre, you can, in width, you can actually see it now. But I presume people always had them at 1 centimetre.
Yes.
But we just couldn't pick up on them. I'm not sure though, obviously. There's no way to know.
Yeah.
Okay, thank you for explaining that, because that is a very common thing to know about. And what I find the most interesting about fibroids is that they can become the size, as you know, of a full-term pregnancy. So you can, theoretically, you could look 9 months pregnant but have no baby. Yeah. All right, thank you. That's really, really helpful. I only have one more question for you, but it's my favorite question, and it's got nothing to do with your job. It's just about you personally. What is one thing that you wish you knew about your body when you were younger?
Okay, same answer would be, I wish I knew how beautiful it was when I was young.
It's beautiful now.
No, because it really changes. And I don't think I appreciated, not just from a physical, like an aesthetic cosmetic point of view, but just that a young body is a beautiful body.
Oh, okay.
And we should look after it and take time out to relax. Your body needs to relax sometimes too.
That is good advice. That's something I need to do a lot more.
Sunscreen. I should have learned about sunscreen.
Yes. Is this tan natural? Is this your natural skin?
Yes.
Wow, it's nice though. It's nice. Well, thank you so much for volunteering your time. I
absolute
can't
pleasure.
Thank you enough. I think my followers are going to find this really helpful, just to have a candid, casual conversation with a normal person who happens to be a very experienced doctor. So thank you. And thank you for all that you do for all of the people out there.
Oh, thank you.
You're welcome. All right, talk to you later. Okay, pals, so that is it for the first ever About Your Body interview. I really hope that you all enjoyed this. Please comment your suggestions below, because I will be doing a whole lot more of these videos. So stay tuned. Thank you so much for listening. Your support means the world to me, and have a good rest of